Welcome to the Cardiac 1, Lecture 2. We're going to start with drugs acting on the renin-angiotensin-aldosterone system, and this is Chapter 44 in Laney. So let's do a little bit of review here. So decreased blood pressure or decreased renal perfusion or low circulating blood volume is going to release renin, which is an enzyme, from the kidney. Angiotensinogen from the liver is converted to angiotensin 1. Then you have angiotensin 1, which is converted to angiotensin 2 by the angiotensin converting enzyme in the lungs. And then angiotensin 2, which is a very potent vasoconstrictor, causes release of aldosterone from the adrenal gland. Now aldosterone, who saves water and sodium, is going to increase your blood pressure. Angiotensin 2 also is going to cause the systemic vasoconstriction. So these two medication classes that you see on the screen there, ACE inhibitors or angiotensin 2 receptor blockers, they tell you what they do, they tell you their mechanism of action in their name. So ACE inhibitors are going to inhibit the angiotensin converting enzyme. So angiotensin 1 cannot be converted to angiotensin 2. That's ACE inhibitors. Angiotensin 2 receptor blockers block angiotensin 2. So it cannot cause systemic vasoconstriction because it's blocked. That's angiotensin 2 receptor blockers. So now let's go back and talk about each individually. We have ACE inhibitors. These end in pril, captopril, lisinopril. These are your ACE inhibitors. They block the conversion to angiotensin 2 by inhibiting angiotensin converting enzymes. They cause vasodilation. They also are going to prevent the release of aldosterone. These are mainly effective for hypertension and heart failure. Some of the side effects of ACE inhibitors: dry hacking cough. This is annoying and frustrating for some patients. It's not life-threatening. However, if it is too much of an upset for them, you want to educate them to continue taking their medication, but notify their provider so that they can either schedule an appointment to switch their medication, or we can decide if it's a side effect that they could live with. Now, some of the more life-threatening adverse reactions: angioedema. This is swelling of the face, swelling of lips, tongue, throat. This is life-threatening because it can swell your airway shut. Hyperkalemia. This is high potassium levels. A normal potassium level is 3.5 to 5. So if they have a potassium of 7.8, they are hyperkalemic, and that needs to be dealt with. That could be a medical emergency. So if they are found to be hyperkalemic, we want to ensure that they're not taking potassium supplements or potassium-sparing diuretics. Another adverse reaction is neutropenia. This happens especially with captopril specifically. And neutropenia is a dangerously low white count, which could pose a serious risk for infection. So, some nursing implications with ACE inhibitors. We want to know their vital signs. What's their blood pressure? Anytime you are giving a blood pressure medication, you need to be taking a blood pressure before to ensure that this is an appropriate medication to give. You want to know what their complete blood count is. That is a lab test, also known as a CBC, which is going to give you your white blood cell count. We want to monitor for that neutropenia, especially if they're taking captopril. You want to ensure that they're not taking any medications with potassium in it. You also want to monitor what their potassium level is. You want to monitor for renal failure. What are their labs? What's their BUN and creatinine? You want to educate your patient to not stop a blood pressure medication abruptly. Instead, call your provider. Just a noteworthy statistic is that ACE inhibitors are not as effective for the African American population. Genetically, they are predisposed to some differences, and ACE inhibitors do not work as well for them. So moving on to the angiotensin 2 receptor blockers, the ARBs, also known as the sartans. So there you can see losartan. These are very similar to ACE inhibitors, except these block the action of angiotensin 2 instead of inhibiting its production. Now, there are less side effects with angiotensin receptor blockers than there are ACE inhibitors. You have less risk for that dry hacking cough, and you have less risk of hyperkalemia. You still have a risk for angioedema with these. Still risk for renal failure, And our nursing interventions are going to be very similar to that of ACE inhibitors. We're going to monitor their blood pressure. We want to know if they're taking other blood pressure agents as well, ensuring that they're not hypotensive. Want to monitor their kidney function, very similar to that of any other blood pressure medication. Moving on to aldosterone antagonists. This is a treatment for hypertension, and these are drugs that block the receptors for aldosterone, so they allow water and sodium to be excreted and potassium to be spared. Hyperkalemia can be fatal. Again, that is high potassium. Normal potassium, 3.5 to 5. Hyperkalemia can be fatal. These medications promote the renal excretion of sodium and water to decrease blood volume and blood pressure. They also prevent or reverse pathologic effects of aldosterone on the cardiovascular system. Here we want to monitor their blood pressure, monitor their labs, such as a CMP, complete metabolic panel, looking at their electrolytes, and if they are taking ACE inhibitors in conjunction with aldosterone antagonists can increase that risk for hyperkalemia. Calcium channel blockers. Calcium channel blockers help regulate the heart, sinoatrial node, and atrioventricular node. Free calcium increases muscle contractility, also known as inotropy. It's going to increase peripheral resistance and blood pressure. So calcium channel blockers block those calcium channels, promoting vasodilation, leading to a decrease in blood pressure. There are 3 different groups. You have the dihydropyridines, you have the phenylalkylamine, and the benzothiazepine. You don't need to know those individually. All I want you to know is that it's a type of calcium channel blocker and which effects it's going to exert on the body. These are medications to treat hypertension and cardiac arrhythmias. Now there's only 2 that are used for cardiac arrhythmias, and we're going to get to that. So first we have verapamil. This causes vasodilation, blocking of the sinoatrial node causing a decreased heart rate, and blocking of the atrioventricular node causing decreased conduction. Some of the side effects for this: constipation, bradycardia and heart block, hypotension, flushing, dizziness. Some nursing implications. We want to know what their heart rate and their blood pressure is. We want to know if they're having any arrhythmias. We want to know if they're lightheaded. Now, diltiazem, another calcium channel blocker, works similarly. It has effects on the heart and vascular smooth muscle. Verapamil and diltiazem are the 2 calcium channel blockers that are used in treatment of cardiac arrhythmias. Next, we have nifedipine. This is kind of our prototype drug for the dihydropyridines, okay? These block calcium channels in the vascular smooth muscle. Has very little effect on the heart, does not treat arrhythmias, okay? It's only going to target blood pressure. These tend to cause reflex tachycardia. You're going to give the medication, their blood pressure comes down, but their heart rate comes up. That's a compensatory mechanism known as reflex tachycardia. Side effects of calcium channel blockers specifically is peripheral dependent edema, especially in the legs. So their legs can get very swollen with these medications. You do not want to take calcium channel blockers with grapefruit juice as well. I hope you've noticed a theme with nursing implications, talking about taking a blood pressure before giving a blood pressure medication, asking if they're dizzy, if they're lightheaded, maybe needing to take orthostatic blood pressures while they're lying, while they're sitting, and while they're standing to see what they're see if they have a drop in their blood pressure or an increase in their heart rate. So here you can see an arrhythmia, that is atrial fibrillation with a rapid ventricular response. So AFib RVR, that is an arrhythmia. We might be using verapamil or diltiazem, depending upon what their blood pressure is, to treat that. On our next lecture, we're going to talk about vasodilators and heart failure.